All right. So now, with that, I'm going to turn the stage over to our first presenters, Lori Banker-Horner and Maureen Clark, who's going to start us off with using technology to plan for the future. Ladies, the stage is yours.
So we're going to figure out this microphone for everybody else. Yep, like I said, there you go. There. So we can all. Can you?
How's that?
I want it over here. All right. Okay.
Thanks, Colony, and we will follow your instructions. We are right on it. So, first of all, I just have to say how humbled and honored we are to just be here with all these great minds and international advocates. So, again, we're just so pleased to be here. As my colleagues well know, I love and I could talk about the ALS Association Center program all day long. But as Colleen said, we have 15 minutes. So, so as we know, ALS multidisciplinary care not only extends length of life, but also enhances the quality of life, as research has shown. And as we move forward in the ALS Association's strategic initiatives of increasing access and utilization of multidisciplinary care, we know that there are questions that must be answered. There's a lot of questions. From identifying areas of need, including those individuals who are unserved or underserved with limited clinic access. And what can we do to potentially meet those needs? We also have to understand that some individuals have access to multidisciplinary care clinics, but aren't attending them. So what do we do about that, and how do we understand that better? So really, it is from both understanding how to make clinics, multidisciplinary care, more accessible, as well as understanding what the factors are that prevent individuals from attending clinics they do have access to. So do we need to establish more clinics? Do we need to build capacity of our existing network? Or do we have to look at different models of care? So as I mentioned, our primary goal is to increase access and utilization of multidisciplinary care. And so this requires really strategic and intentional decision-making, which requires strong, accurate data, and that will help inform resource allocation, smart utilization of resources, whether it be direct staffing, direct funding or staffing, or investment in different models of care. So I'm going to give you a very, very brief Cliff Note explanation of our center program in the United States. So the ALS Association Center program was established in 1989 and expanded after its inception as the National Association, and the chapter network also expanded, keeping in mind that the actual ALS Association was formally founded in 1985, so this is 4 years after. Now, currently, we have two different formal designations. We have Certified Treatment Centers of Excellence, and we have Recognized Treatment Centers. And right now, currently in the United States, we have 76 Certified Treatment Centers of Excellence and 18 Recognized Treatment Centers. Now, each of these centers, to really achieve the designation, requires that they go through, there's very specific criteria and a very robust process for them to achieve this. And it's really, I'm very proud to be part of this and work directly with these clinics. Now, the primary difference between Certified Treatment Centers of Excellence and Recognized Treatment Centers is research. All of our certified treatment centers are involved in ALS-specific research. So 76 centers around the United States. So, and also one of the key pieces is that there is an ALS with the full multidisciplinary care team. It's a very important, and it's a criteria that a member of the local ALS Association entity is part of that actual team and is ensuring that the individual coming to that clinic has the resources and support of the ALS Association. So we do have a different type of clinic, those that aren't formally designated, but just really have ALS specialist involved. It may not be a full multidisciplinary team, but it really is a strong resource, a referral source for individuals. And these are called affiliated clinics. And again, this could be a clinic that is currently building. It could be a clinic that maybe there's a neurologist that really has a passion and specializes in ALS. And also this could be in a clinic that is in the queue to be formally designated. And again, these are affiliated clinics, and at present, we have 105 of those around the United States. Now, between our formal designated clinics, there's about approximately 12,000 people within the United States that are seen through those clinics, and an additional 3,500 that are seen through affiliated clinics. So knowing where we are and all the information that we know, we really have to understand more. It's imperative. And within the last 2 years, the ALS Association has developed a really strong data and technology team. And this was sort of the turning point when we came together to utilize the information that we have to really move it forward. And Maureen and I, we met initially regarding the clinic locator tool, as you'll hear in the follow-up presentation that she'll be involved in. And as we talked, we realized what could be, and that we needed to marry data and technology with care services to move our understanding forward and understand which each of us brings to the table. We learned a lot together, and Maureen is going to share more of what we learned.
All right. Hit the green button, right? So we'd like to share a few examples of data layers and source utilization we can use to help us determine where to focus our efforts. Over the past 2 years at the ALS Association, we have begun to use a technology called GIS to help us begin to think spatially and use this knowledge to explore, understand, and strategize for the future. GIS stands for Geographic Information Systems and is known as the science of where. GIS is a system that allows us to use software to make sense of data when placed on a map. We can take spreadsheets of data and create layers that help lead us to identify patterns, occurrences, proximities, and similarities. This portion of the presentation will show at a high level some examples of data when used with technology. We'll give it context and help create questions to consider. If we focus our attention on this area of the United States, you'll see 3 of our states, Minnesota, Wisconsin, and Michigan, highlighted in red. This will be our focus area for the following maps. So with data analysis, and more specifically spatial analysis, we need data and we need something to provide context. So we put it on a map. If I overlay a sampling of our persons with ALS on top of our Minnesota, Wisconsin, Michigan example state layer, outlined here in red, you immediately see our data coverage within this area. The blue, red, yellow heat gradient provides the density and coverage. We will be sharing our data layers with you via these heat maps to protect the privacy of our community. So you'll get a general idea of location. With this tool, we can see the reality of where people are and a general sense of how many persons with ALS are formally registered with the association in our example areas.
And there are questions, really, that we may consider as we're looking at this. And as Maureen and I worked together, more and more questions came up. So what about those that have not registered? How do we find, what do we do for outreach? Should we focus some attention on the northern halves of these states? And these are just a couple questions that have come up. And what about those closer to the Canadian border? And, you know, again, the different models of care. How can we reach these people?
Yeah. Now, if we add our clinic layer to the map, broken out by certified, recognized, and affiliated, you can begin to think spatially on where our population may decide to attend a clinic. We have 11 multidisciplinary and 3 affiliated clinics in our example area. We can see there are several clinics that are well placed for the population based on the density, but also areas that we would need to consider what to do to offer care.
And also understanding, and this brought up, who is attending a clinic and who is not. What are we doing about those people in the outer areas? Again, it's important to note that these are just persons with ALS that are registered with our association.
With this example, we can see two separate layers representing the persons that are registered with our association and attending clinic on the left, and those that are not attending a clinic on the right. Coupled with analysis, we could determine spatially how many persons with ALS are and are not attending a clinic. With these separate map layers, we can decide to focus our attention on the persons that are not attending and try and understand why. Or we can help determine what is working to help maintain attendance.
And the questions again, every single time we look at these overlays, there's questions that come up. And do we think about establishing a clinic in the northern areas again? Do we need to consider transportation options, work with our international partners? Do we offer telehealth options? The list goes on.
Another piece of analysis we can do is to identify a typical drive time to a clinic. Along with determining clinic attendance, we could use this analysis to identify gap areas in coverage, and it could lead to initial steps determining where having a new clinic might be useful. In this example, we have chosen 90 minutes as an average drive time. On the left, this blue polygon is called a service area that measures the 90 minutes of travel time to a clinic. The map on the right shows the persons not attending a clinic in the brown, and also not within a 90-minute drive time around a clinic. We could use these layers to determine, is 90 minutes a typical drive time, or is it further? Is distance of travel a factor in clinic attendance? How many persons are attending, not attending, within and outside this specific drive time? Ultimately, the point of using GIS is that we can help find places for clinics for people who live where drive time may be an issue. And again, having various map layers of data helps us to understand the questions that need to be answered. In this example, we have run a process called location allocation. If we determine that 90 minutes is an average drive time to a clinic from our previous slide, and we determine that a drive time affects clinic attendance, we can try this location allocation process. If we then add a layer of cities over 20,000 in population and run analysis on our layer of persons with ALS not attending a clinic within a 90-minute drive time, we can identify a potential city within our examples that could serve the greatest number of persons. The identification of this example city is just one decision-making aspect used when exploring clinic placement.
And I think that's one piece that we really want to stress. This is one piece. And does this mean that all the requisite providers and professionals are going to be available? We all know that it takes a lot to build a clinic. So does this mean too that all the people will attend the clinic? No. But what it is it's a starting, we have a place to start in determining where the next clinic could be in a more modernized and intentional manner.
In the next few slides, I'd like to show just a few of the various external sources we can use to overlay our ALS data to get a spatial view. These maps, used in conjunction with our data and analysis of the data, help us begin to think about priority care areas. You can see our familiar heat map of ALS data in the blue, red, yellow over top the external sources. On the external sources, the darker the color in these maps is the area we could prioritize to focus our attention. If we look at the map on the left, this is from the United States Department of Health and Human Services. This map is showing medically underserved areas. These areas identify geographic areas and populations with a lack of access to primary care services. These groups may face economic, cultural, or language barriers to health care. The map on the right is the Center for Disease Control's Social Vulnerability Index. Social vulnerability is determined by 4 themes such as housing and transportation, minority status and language, household composition, and socioeconomic status. This map shows the areas that are socially vulnerable. In conjunction with the medically underserved areas, we can begin to quickly determine where to focus our attention. And again, on the right, we see our ALS heat map layer. We overlay on the U.S. Census American Community Survey data relating to health insurance coverage. The darker the color, the higher percentage of the uninsured. And on the left, the layer is symbolized to show the percentages of households with no internet connection. Again, the darker the color, the potential areas of focus for us to strategize how we proceed with supporting our community. So I'm hoping that the presentation showed how we can use ALS Association data layers along with analysis and readily available governmental sources so we can prioritize where to serve our population. Maybe take a look and see what kinds of sources you may have readily available that you could provide in your country or in your county or city as a way to get started on steps with your data. So thank you. We look forward to working with you, talking with you, and I want to give you a special thank you to Pat Dolan, whom I've worked with closely with this past year on some of the analysis the association has performed. And you'll meet Pat in the Global Clinic Locator presentation coming up soon.
And I just want to add, Maureen and I have learned so much working together, and this collaboration we've both learned, and it has informed the center program as well as realizing the impact on advocacy, development, research, and so many other areas. It has helped open the door to additional questions to better serve those living with ALS, and that's the goal. We welcome your questions, and we look forward to talking with you throughout the Alliance, so thank you.
You did great.
Thanks.
Stay up here, stay up here. So do we have any questions? Nancy, I'm going to look at you and kind of try to scan the audience as well.
Great.
Yes, Catherine.
Do you know,
I think a microphone's coming your way. If you don't mind waiting, just so our virtual participants can hear all the questions.
do you know what percentage of total patients in the US you have registered with the ALS Association?
Percentage, Dean? Did I call that out?
I'm not quite exactly sure, but if we have 12,000 in that list registered, we would estimate that there are about 22 to 25,000. So I would say we're at or about the halfway mark.
So do you have access to other data sources to find out where the rest of the people are, to overlay on that map?
We have ideas. We have the National Registry, which typically, oh, go ahead.
Hi, I'm Brian Frederick with the ALS Association. I just wanted to, those of us in the back who work with these numbers every day, wanted to point out that there's about 30,000 people we estimate in the U.S. who are living with ALS, MND, and at any year, in any given year, we have about 20,000 people registered. So we're touching about 2/3 of the people in the country.
And we're in the process of collecting this data and putting it into these data sources right now. So we're working through that piece. Nancy, is there something online?
It says, interesting demographic data. Is this information available to researchers to recruit for clinical trials?
Yeah, most of the governmental sources through the U.S. Are right. You just do a Google search, and census, CDC, sources like that are available. Yep.
I can also add that we are working on a clinical trial match program. And so I'm not sure if we're talking about that in the next couple of days, but that's certainly something that the association is willing to share in order to marry up the data between who's in the database and then what trials might be appropriate for those individuals. So we're debuting that at this point. Other questions? I think we're doing good on time. Yeah, Marcella?
Have you had any successful accomplishments with this data, taking it forward to for public policy for the government? Like, have they put more clinics? Have they put more transportation for the patients or something like that?
Just beginning. So we're scratching the surface. So as our team builds, more people are on more teams. We are starting to use the data that we've all collected, coming together as an organization to build that, use those data sources to help make decisions. Regardless of what it is, use our data along with governmental sources, other layers over top. You can figure it out. It's just helpful to do that. So.
Great question, and that's the power that we see in some of the data. Pablo, I think I saw your hand go up.
Thank you. So could you describe a little bit more how the system works, the GIS system works, and how do you instrument that? And in case any other country wants to get their hands on that software to use it in their own countries, how can we do that?
Yeah, and I will, I'll put Amanda on the spot at the moment. Amanda works for ESRI, Environmental Sciences Research Institute. Systems, see, ESRI. ESRI is the company, it's a global company that is a mapping software company. ArcGIS is the name of the software, and it's a piece of software. You learn the software, you input spreadsheets of data, and with that data you can become familiar with where it is on the place of the Earth. So if you have some sort of locational element to your data, you can map it, and that gives you more of a spatial awareness of the type of possibilities that are out there. So. Yes, they have ArcGIS online. They have ArcGIS Pro. And I don't know if they're still using ArcGIS Desktop. It's available. Yeah, so, but yeah, it's available. Yeah, and we at our ALS Association use a subscription service with them. It's a yearly subscription, very inexpensive for nonprofit organizations. So, so I highly recommend getting familiar with that. So it takes some training, obviously, but Esri also offers training as well. So
Great, thank you. I think we have time for one more question. I thought I saw a hand in the back, but maybe not. Nancy, anyone else online? Okay, that's good. So thank you very much for this presentation. This is work that the association has started and really embarked on over the past couple of years, I would say. And I know that Maury and Lori are also working with Kathy Cummings and trying to understand how we can, as a global community, start to really think about how we use data together to understand where our need is and where we go forward. So thank you both.
Great.
Nice job.
Thank you. All right, so